Welcome to the Low Carb Conferences podcast. I'm your host, Dr. Jeff Gerber, and we have a special guest today, Dr. David Diamond, and he's best known as the LDL skeptic on social media, and he'll be joining us at our conference in February. So how are you today, David?
I'm doing fine. Thanks for inviting me, Jeff.
Well, it's great to have you. And just a little bit more about David. David has a PhD degree in psychology, and he spent most of his career researching in the area of the neurosciences. He's well published in the literature, and as an insider, he's familiar with the pharmaceutical industry. On a personal journey, David became interested in heart health and low-carb diets and was appalled when he reviewed the literature. And he can maybe tell you a little bit more about how he got interested in that. But using his research skills, he continues to critique the literature and also contributes to that literature as well. So David, can you give us a little more background and tell us a little bit about your past and current areas of interest?
Well, again, thanks so much, Jeff, for inviting me to be on today and to speak next year. Let me just add, I'm in a psychology department, but I don't have a degree in psychology. So my PhD is in biology with a specialty in neuroscience. And so both undergrad, grad school, my emphasis was biology, and I had a passion for understanding the brain. And so it was actually over 40 years ago that I became a neuroscientist. And I've been very well funded by the government. I've also done extensive funding from drug companies in my neuroscience research over the course of 40 years. But the reason why you've invited me today and the reason why I'll be at the meeting has nothing to do with my neuroscience research. What happened was, as my career was developing, also was an increase in my risk for a heart attack. And it was 25 years ago that I was given some very bad news about my lipids. My triglycerides were astronomically high. My HDL was extremely low. Any expert on lipids would know that the ideal ratio, triglycerides to HDL, you're typically looking at, you'd like them to be 1-to-1, maybe 2-to-1 ratio. My ratio was about 25-to-1. And so this again was 25 years ago, and my doctor told me I was at extremely high risk for developing a heart attack and urged me to go on a statin as well as some other medications. So I knew a lot about the brain, but not much about heart disease. So I decided to put my background in biology to good use. I started studying triglycerides, heart disease, to try to understand why I was at such high risk. It took me a few years to figure it out. And first of all, I happen to have a genetic anomaly. That's what enables me to have this 25-to-1 ratio of triglycerides. And my triglycerides were 800. My HDL was like 30, which was abysmal. And it's certainly accurate to say that really is very high risk. And at the time, I was eating very little meat, very little fat. And I thought it was really great. I was eating bread without the butter and the cheese. So when I just studied the biology, I realized I was driving up my triglycerides by eating so much bread. And I've been able to dramatically reduce my triglycerides by about 75%, raise my HDL by about 25%. So I'm at much lower risk now. I've also lost a good bit of weight in the last 25 years. In the process of improving my own health, I have read the literature. And as you said, yes, I have been first alerted, then alarmed by what I have felt is a misrepresentation of what we really should be afraid of, this misrepresentation of the cholesterol research, which I think has resulted in unfounded fears of cholesterol and unjustified appearance of benefit of lowering cholesterol with various pharmaceutical approaches, particularly statins more recently. And what happened was about 10 years after I started learning for myself, I happened to be invited to give a talk to the public. I didn't even know it was going to be recorded. And it was put on the internet. And the next day I saw that there were 100 views, and I thought, wow, 100 people have watched the talk that I gave. And by the end of the week, it was 1,000. And by the end of the month, it was 10,000. And then it grew to over 200,000 people had watched this talk that I gave. And as a result of that, I've gotten a good bit of attention. And I think what's really important is, as an academic, I approach this objectively. I mean, I have no bias whatsoever against research supported by pharma, since that's my research as well in my neuroscience. And I didn't come into this looking to criticize cholesterol research at all, since initially I knew nothing about it. This really is my personal adventure, which I will be sharing with people, both the science itself, as well as what I have published is my view of deception in this field. And that's to promote the idea that cholesterol itself is atherogenic. High cholesterol automatically puts you at risk, and particularly LDL cholesterol. And that statins are wonder drugs. Take a statin, you reduce your risk by 50%. Isn't that fantastic? So I've learned a good bit about deceptive statistics, and I've published papers on this. I've learned a good bit about cholesterol itself, and I tell you, I can't emphasize enough how I have benefited from just dozens of other people who've given talks, written books, other scientists, and I've been able to work with these people, including cardiologists, and publish papers on this topic. So ultimately, I just want to emphasize this is entirely science-based, in which I will be presenting to me the science of what really causes heart disease, and whether or not we really need to worry about high cholesterol, in particular, if we're on a low-carb diet.
Well,
how's that for an introduction?
That's a perfect introduction, David. And thanks to you being in this sphere that we have benefited greatly from your expertise and your knowledge. And I really have to back up, and it was what I would refer to as your signature presentation way back then when you were happy there were 100 views that really helped to explain to me some of the pharma manipulation. And I want to just briefly mention that to number one, make sure that I got it right, and just to ask you some additional questions about it. And so that talk was discussing absolute versus relative risk reduction. And just for the audience to briefly explain that, let's say that you have a 1% chance of having a cardiovascular event. And then there's a wonder drug that says it will reduce your chances of having a cardiac event or a heart attack by 0.5%. So that's an absolute risk reduction of 0.5%. Now, another way to represent that data is if you look at the difference between 1% and 0.5%, that's 50%. So that's a 50% relative risk reduction. And what pharma likes to do is to report relative risk because it's a bigger number. So have I explained that properly?
Oh, thank you, Jeff. So you covered it for me as far as absolute and relative risk. Just to emphasize, a 0.5% reduction, which sounds really trivial, is actually a 50% reduction when you go from 1% to 0.5. And what you'll see in the advertising you'll see presented at a medical conference is what's called the relative risk, which is the difference between the percentages. And so you'll see that statins reduce heart attack rate by 50%. But the actual numbers are incredibly small. Now, what I'd like to also emphasize is before the statins were developed, this same abuse of statistics was present for decades before you had the statins. So there was a trial in 1984, the LRC, the lipid reduction trial. And it found essentially almost no relation between cholesterol and death from heart disease. And so in one example from this trial, these are middle-aged men. And I like to say that in most heart disease studies, other than heart failure, in almost all studies looking at heart disease, almost nobody dies. And I say these people are horribly uncooperative because death is rare. And in fact, heart attacks are actually quite rare in most studies. I mean, it's usually somewhere around 1% to 2% of the people actually have a heart attack. And so when you're talking about a reduction of risk with drugs, you're really talking about a very small amount. But in this study, what you actually were just looking at the rate of deaths in relation to cholesterol. And so what you have is incredibly healthy people who were not hypertensive, um, um, and were not overweight. And you had about 0.5% of the people died who were relatively healthy. And when you look at this study, at the people who had the highest cholesterol, it was like 0.65% of those people died, and this is over 7 years. Whereas the people with the lowest cholesterol, 0.16% of them died. So it's almost nothing. But what did the authors conclude? They concluded that there was a 4 times greater risk of dying with high cholesterol. 4 times. And that was the news of this story, because 0.65 is 4 times 0.16. And so this is the abuse of statistics that I guess I've really emphasized in my talks. And it's gone on for decades, and it was even before the statins were developed.
So I call it, it's a British term, this statistical shenanigans, David, but I do have to credit the study because they looked at mortality. And so that's really an important endpoint measurement versus events. So, but again, that's a great example of how they amplify the data. So one thing
we like to demonize pharma, which I think is justified. And understand that the pharmaceutical companies, their job is to make money. And I frankly don't have any problem with that. But realize these are academics, these are clinicians who are manipulating the data. The 1984 study was done by clinicians. You have other studies. 1986 study, Mr. Fit, was performed by clinicians who, you've got studies in which you're lowering cholesterol with cholestyramine, which preceded statins. And these are people who were committed to making sure that we feared cholesterol. This wasn't just drug company sponsored research. It became sort of a crusade in the 1980s to convince everyone that cholesterol caused heart disease. So this is more than just pharma. This was just a commitment by people at the highest level to get everyone to fear cholesterol. And I kind of believe they were sincere. These are not evil people. They were committed to the belief that cholesterol caused harm.
I appreciate your comments, David. So one question I had, I think of relative risk reduction, that it serves a purpose that it perhaps gives you data about a population, whereas absolute risk tells you about an individual. That's how I've always thought of it and expressed that to our patients and people. Does that make sense?
Well, the relative risk alone, there's nothing wrong with it. Relative risk by itself gives you a relation between one population that actually has a disease and another population that has a disease, and you're looking at the effect of a treatment. And so you can say, well, if 1% of the people that are not treated have a heart attack and 0.5% of the people that are treated have a heart attack, that's a real statistical difference. You need both. Yeah. You need to know the real difference, which is 0.5%, and you need to know that that's half, that's 50%.
Well, I'm going to take that as a yes. So it's actually relative risk does look more at populations, and absolute risk, I think, that tells you what your individual risk is. But
well, let me add, sometimes, especially whether it's heart disease or other diseases, for example, let's say you're developing a drug that saves people from dying from Ebola. And let's say that death is almost 100%, but it's extremely rare that anybody gets Ebola. So the absolute risk in the whole population may be extremely small because very few people are going to die or even to be exposed to Ebola. But if you can find a drug that, let's say, cuts it back from 1% to 0.5%, the death from 1% to 0.5%, and in the case of Ebola, well, that's pretty good. You're saying you're cutting back death by 50%, and it's an extremely rare disease. So both numbers are really important. And I have to say, academics for the past 30 years have emphasized you really want to know both. You need both absolute risk and relative risk. But as you're sort of implying, if you only give relative risk, then you don't really know the total risk. For example, again, let's say you have a study in which 2 people out of 10,000 have a heart attack, they're placebo, and 1 out of 10,000 have a heart attack given a drug. The absolute risk difference is 1 out of 10,000, which is pretty trivial. The relative risk is 50%, going from 2 to 1. And that's why you really need both. If you're going to really tell your patient what's your real risk. Now, what the people who are statin advocates have also done is they don't use relative risk in talking about adverse effects. That's where they will give you the real raw data. And in fact, you can look at, if you look at the Jupiter study in which Crestor is presented, this is kind of remarkable to me. So the rate of heart attacks in the Crestor, the Jupiter study, was about 0.7% in the placebo and about 0.35% in the Crestor treated people. So again, we're talking a trivial number of people, barely statistically significant. They had like 20,000 people in the study. But they said it literally, you can see it in their original paper and in the commentaries, a 50% reduction in heart attacks. And that's why it got approved by the FDA almost immediately. But realize the actual difference is 0.35%, which is pretty trivial. When it came to the development of new onset diabetes, it was almost as large. So in your placebo group, the new onset diabetes was relatively low, maybe 0.3%. But in the treated people, it was like 0.5 or 0.6%, which, again, on a relative risk basis is rather large. But they said, no, it's only 0.3%. And even though statistically significant, they said, we don't think it's real. In the paper, they said, we don't think it's real. Meanwhile, it's been followed up. There's a lot of good evidence that statins do increase new onset diabetes.
So they minimize the risk using absolute, and they maximize the benefit.
Even downplay the statistical significance of the effect.
Well, that's great, David. This wasn't even the heart of our conversation today, but it's always a great conversation. And you know that, myself, I'm very passionate about nutrition and cardiovascular disease. So this is a great topic that we're going to discuss today. So regarding the issue of, the manipulation of data, I briefly wanted to mention, and this is near and dear to your heart as a neuroscientist, that recently there have been some news about Alzheimer's disease research, and that the data was fraudulent. And I only bring that up because I'd like you to compare and contrast and to ask, has there been any fraud in other areas of research that you're familiar with?
So thanks for bringing that up, Jeff. I've actually published quite a bit on Alzheimer's and related actually to that fraudulent work. So I worked with a group here about 20 years ago, and the fraudulent work had to do with an animal model of Alzheimer's, and I actually worked on an animal model of Alzheimer's prior to that. And out of that, the idea is that you have amyloid is a protein that's been studied, frankly, for over 100 years, that appears to be involved in the development of Alzheimer's. And so that you can now make an animal that produces amyloid. It's called the transgenic model of Alzheimer's. And we worked with one, and we actually worked with a drug company that came up with a vaccine to rid the brain of amyloid. And when it was tested on people, it actually ultimately ridded their brains of amyloid, and yet the dementia developed normally. But a few years after we did our work, someone came up with a novel form of amyloid that they said was actually causing the Alzheimer's, of which they then developed treatments. And it turned out that work was completely fraudulent. And that's just been revealed recently. So 2 things. The first is, I have never accused pharma of committing fraud. What I've always talked about is they are out there being very accurate. I mean, they will tell you the real benefit is like 1% or less of their drugs. And when it gets published, people talk about it being 50%. That's, as you say, statistical hijinks. You're playing with the numbers. But frankly, if they wanted to commit fraud, I think they would have really played around with the real absolute risk and say, well, we really did reduce heart attacks by 50%. And they don't do that. So unlike the Alzheimer's work, I don't think this is actually making up any data, because their data are really awful when you look at the work that's come out of the drug companies.
Yeah, and I think they manipulated images is how the story
Well,
goes.
the person actually, it was 2006. The person actually created artificial images of this version of amyloid, which is called amyloid 56, to make it appear as if there was a particular kind of amyloid that caused Alzheimer's. But it's actually a very relevant topic. There has never been a drug that has been beneficial for Alzheimer's. No treatment whatsoever slows the onset of Alzheimer's, stops Alzheimer's from developing, and there's no treatment for Alzheimer's once it's diagnosed, despite the fact that the FDA just recently approved a drug that's extremely expensive and extremely useless. When you look at dementia, it's very much related to low carb. When you look at the people who develop dementia, you're talking about the people who are metabolically damaged. You're talking about people with metabolic syndrome. You're talking about people that are much more likely, those who are obese, more likely to develop dementia. People are extremely healthy, high stamina, people who exercise, an extremely low rate of dementia. And so ultimately what we're really talking about is the ability of the brain to use energy. And there's a vast amount of work now. Stephen Cunnane is one of those who's doing fantastic work on ketogenic diet and brain health. So when you've got the brain using ketones as well as glucose, that appears to be optimal as well as the heart. And so those people are going to be much more resistant then to developing dementia compared to someone that is sedentary, overweight, hypertensive, and diabetic.
So I'm happy to say that research is heading in that direction.
Right.
And thanks for bringing that up. So what I really wanted to dive into is your recent paper, and this will be the context of your discussion next year at Low Carb Denver. And I just wanted to see if I can share my screen. Can you see that, David?
Yes.
Yeah, so this is the paper. And
a slightly controversial title.
It is a provocative title.
Yes.
Statin therapy is not warranted for a person with high LDL cholesterol on a low carb diet, hard stop. And so I must say the paper is fantastic because it's really a summary of cardiovascular disease, the diet heart hypothesis, the lipid hypothesis, and as it relates to low carb diets. And there's two components to this paper. And the first component is that of low carb diets and the diet heart hypothesis and its effect on cardiovascular risk. And the second component to the paper is the lipid hypothesis, specifically lowering cholesterol via medication or not, and its effect on cardiovascular disease. So maybe you can spend a few minutes and summarize the findings.
Sure. So as you just gave the different categories in our paper. So we really emphasized covering the literature broadly. I also emphasized there are things we know and things we don't know. And we don't know for sure if high LDL cholesterol when someone's on a low carb diet is beneficial or harmful. There has never been a study. First of all, there's never been a study on people with low carb diet looking at cardiac events. So we don't know if the diet itself improves or has any hazardous effect. Of course, since almost all the biomarkers go in the right direction, it's very likely people will have fewer coronary events, fewer strokes, fewer heart attacks. But as a scientist, I said, we don't know. The second thing is we don't know if a person on a statin with high LDL versus a placebo will have a benefit if they're on a low carb diet. So this is part of the problem. See, I had such a backlash from some cardiologists who say this is reckless. How can you say that there's no statin therapy is not warranted? Now, you understand, it's kind of a cautious title. We didn't say do not take a statin. And I'm emphasizing I don't give medical advice. What we're saying is there's no scientific justification to lower your cholesterol with medication if you're on a low-carb diet. And first of all, we need to understand, people have emphasized LDL-C. For 50 years, people have said if your LDL-C goes up on a low-carb diet, that's harmful. And LDL-C being LDL cholesterol, that's the total amount of cholesterol that's in all of your LDL particles. So for everybody to understand, the LDL is contains cholesterol. It can have different amounts of cholesterol. So the LDL-C is just the total cholesterol in all the LDL particles. Well, there are different kinds of LDL particles, which we reviewed. And one thing that's crucial that is conveniently ignored by the people who say I'm an LDL denier, I'm a statin denier. One component in the LDL-C measure is lipoprotein P, a small a, lipoprotein A, which appears to be, it can be atherogenic. And it's very similar to LDL. So when you're just looking at total LDL, this one gets kind of carried along, but its function is very different from your conventional LDL. So LP little a actually is structurally different from LDL, but it gets included in the assay. And so that's one thing that's very important to keep in mind. The other thing is there are different sizes to the LDL particles. And we know that when someone is in good shape, someone exercises, especially if they don't eat much sugar, they have low blood sugar, what you see is a dominance of the large LDL particles, and you see much fewer, a low percentage of the small LDL particles. And it is the small LDL particles that are associated with more heart disease. And we emphasize this. It's not the small LDL particles that are causing the heart disease, but it is the entire context. You find a dominance of small LDL particles when someone has diabetes, when someone has high blood sugar, when someone is hypertensive. And so what you have is metabolic damage. You have basically a storm of activity of which the small LDL particles are included. You don't see a dominance of the small LDL particles in someone that's really healthy. That gets us now to low carb diet. And we reviewed just dozens of studies, all showing that LDL-C may increase in a small subset of people. But what you see is that balance between the large and the small goes clearly in favor of the large LDL and a reduction of the small LDL, along with an increase in the HDL. That simply means that your metabolism is getting healthier. So I'm not talking causation. I'm not emphasizing the small LDL causes heart disease. But what you have is a storm. You have damage. When you have high blood sugar and you're hypertensive and you're smoking, then you're going to have a dominance of small, dense LDL. Your LDL-C may rise, but in part because your large, buoyant LDL also rises.
So, David, you're simply describing addressing atherogenic dyslipidemia, insulin resistance, and metabolic syndrome.
Hypertriglyceridemia also goes along with it. Now, so there is actually a study that shows that statins will reduce the large buoyant LDL, but not the small LDL. So we need LDL for healthy metabolism. So in fact, the statin potentially is reducing our beneficial LDL and not helping to reduce the bad LDL, the small dense.
So before we get into the medication side of the things, I would like to just give a disclaimer to the audience, and you already said it, that you're not a doctor, and
not a physician.
Right, I'm a physician, and
right.
But this is still informational, and by all means, if you have questions about diet and medication, you should always go talk to your personal healthcare professional. But right. With that in mind, David, and we've talked about this in the past, I absolutely agree with you that we should be addressing, insulin resistance and the metabolic syndrome and atherogenic dyslipidemia, as a primary intervention to address not only weight, diabetes, prediabetes, but also heart disease risk. And for primary prevention, and this is the area where we've really gone back and forth, that I think that clearly the low carb diet will benefit, and also in secondary prevention. And so there's really no argument there. I think what we've been discussing in the past is how do you approach a patient who's on a low carb diet who unfortunately has had a cardiovascular event, meaning what do you do with them in terms of secondary prevention? And also, I know that you are a proponent of heart calcium scores in the right context, because you talk about that in the paper. And so I've mentioned that we use the heart calcium scores, particularly looking at volume in terms of progression. We also look at the density. But if a patient has a very high calcium score, say over 400, we put them in the category of secondary prevention. And the question is, well, what do you do with that kind of patient who's on a low carb diet, whether or not medication would be indicated or not?
So I can understand the challenge you're faced with as a physician, and so part of the problem you're faced with is there is no medication to lower coronary calcium. It's not like you can put a patient on a drug and say, okay, we can lower your calcium, you'll lower your risk. And frankly, we don't fully understand what raises coronary calcium. We don't have enough research, but I can tell you one thing we're quite certain of is that statins increase coronary calcium. I am often surprised when I see physicians who have a patient at risk who has high coronary calcium and says, well, we need to get you on a statin. And first, as far as I know, there has no evidence of a benefit of statin treatment for someone with high coronary calcium. There is an associational retrospective study that was published a few years ago of people on a statin had fewer events when they had high coronary calcium. But we don't know about what's going on with that study. We don't know if the people stopped smoking along with taking a statin. So that's just an associational study. The other thing to keep in mind, and I find this remarkable, when it came out, and there's almost no debate on this, that clearly statins increase coronary calcium, this is in the context of everyone agreeing that coronary calcium is a bad thing. I mean, nobody was saying, isn't this great, you got more coronary calcium. Well, when the papers came out one after another of statin use associated with increasing coronary calcium, suddenly coronary calcium became a good thing. And why did it become a good thing? Well, saying, well, the statin draws in the calcium to stabilize a soft plaque. And this is just fantasy. There's no evidence for that whatsoever. The evidence is absolutely unequivocal. Statins will increase coronary calcium. Now, statins also, I think, completely separate from that, because we know more coronary calcium is not a good thing. Statins are actually what we call dirty drugs. They have many effects. So statins are anticoagulants, they're anti-inflammatories. Statins have so many effects, some of which are probably beneficial for people. And so it may very well be that when in the context of coronary calcium, the statins could be increasing coronary calcium, but at the same time acting as an anticoagulant, which actually results in a small rate of reduction of heart attacks, which has nothing to do with LDL or the coronary calcium.
Maybe superoxide dismutase as a...
Sure. Yeah. I mean, they're affecting oxidation of LDL. So now, there is a very nice paper, and we potentially can go into familial hypercholesterolemia. There's some very nice work in which we're looking at people on statins and looking at coronary calcium. And what you find is there's no difference in much of the work, no difference in LDL in the people with FH. These are all people who have extremely high LDL because of a genetic anomaly. And it's coronary calcium that tells you which people have the heart attacks, not the LDL. In the people who have LDL, that could be 300. And when you look at other markers, I think what's most important is, and this is in one of our papers, the people with high coronary calcium have extremely high fasting blood glucose. These are people in the pre-diabetic, diabetic range. The FH people with LDL of, let's say, 250 to 300, with no coronary calcium, have very low fasting blood sugar. So if we're looking for a connection of coronary calcium to something we can control, there's some evidence that being healthy, having low blood sugar is more likely than to result in low coronary calcium.
Yes, I love in the other paper you wanted me to mention that it discusses FH. That one's titled Dietary Recommendations for FH, an evidence-free zone, meaning that there's really no evidence to support.
So, well, let me say a couple of things about that. So the first thing is, because these people who have a genetic anomaly, because the LDL doesn't bind very effectively to the LDL receptor, what actually happens is the liver adapts. Cholesterol is so important. I think this is the reason why people with FH have high cholesterol. Because the LDL doesn't bind very well to the receptor, the liver dramatically increases LDL concentration to be sure that you can get that LDL into the cell. That's the reason why these people have high LDL, because LDL is so important. People with familial hypercholesterolemia have a normal lifespan. And as they get older, they in fact have a lower rate of heart disease. People over the age of 60 have a lower rate of death, according to each decade, than people who don't have FH. And in fact, there's no increase in death from heart disease in people with FH over the age of 70, which is when you see a dominance of people dying from stroke and heart attack. The reason being, and I kind of think of God is playing games with us here. He has stuck in that high LDL just to muck with our heads. Because what is killing people with FH prematurely is a genetic tendency to have hypercoagulation, excessive clotting. And so when you look at the people who die young with FH, these are the people who have extremely high clotting factors. So there is a second genetic anomaly that comes along with having FH. And a subset of the people with FH have extremely high levels of clotting factors, such as fibrinogen.
Are you saying that the clotting propensity, is that part of the metabolic syndrome, that they're at greater risk than those without FH?
I don't think it's related to metabolic syndrome. I think it's that these people hypersecrete clotting factors. They also hyposecrete the factors that can actually reduce clots, called fibrinolysis. So we make clots and then we break down clots. So the people with FH that die of heart disease young, first of all, they're the smokers. If someone has FH, there's just no tolerance for smoking. Now, smoking triggers clotting. One of the reasons why smokers have more heart attacks is when you smoke, you trigger fibrinogen, then to make your platelets more sticky, to aggregate. And so hypertension. The people with FH who die young have hypertension. Both hypertension and smoking trigger clotting. And so it's all connected. Is high blood sugar, the people with diabetes who die young with FH. High blood sugar triggers clotting. Now, and Malcolm Kendrick has a really great book out called The Clot Thickens, all about how clotting factors, and we published a paper on this as well, clotting factors are the common element in why people develop heart disease. LDL turns out to be irrelevant.
So the reason that FH is so important, and you discuss this in your paper, is that when it was discovered, it was used as an argument to say that LDL cholesterol is a causal agent. And you just so eloquently just explained that if that was the case, the longer you're exposed to the toxic molecule LDL, your risk of death, heart attack would go up. But you just said that the elderly people with FH, the risk actually drops.
It makes no sense that these people with FH can live long, healthy lives with astronomically high LDL. And in fact, it's quite interesting there are statin advocates who have made objective observations. They've published papers showing that, in fact, if you can do a genealogical study looking back into the 19th century of people who were likely to have had FH, those people live longer than the general population. And the reason is really very simple. LDL is a part of our immune system. So LDL works with the white blood cells to scavenge bacteria and viruses. The people with FH, first, this is some really nice work from statin advocates. This isn't just like an internet cult finding. It's published in the medical journal from statin advocates that the people over 60 years of age who have extremely high LDL have a dramatically lower rate of cancer and death from infectious disease and a normal rate of heart disease, which is why they have a much lower rate of death after the age of 60. LDL is a part of our immune system. If you don't have sufficient LDL, you're much more likely then to develop a cancer or an infectious disease. So this is the misinformation, the lack of appreciation for how important LDL is to our overall metabolic health.
So, David, you're not alone in these comments, although they are provocative, but I just want to mention that you've worked with some of the greats, including Ufi Rathnikoff, Michael DeLauer, Malcolm Kendrick, Matt Budoff, just to name a few, who agree with some of the things that you're saying. So kudos for, again, working with some of these researchers, scientists, and physicians.
Let me also emphasize, Ufi Rathnikoff was around long before I was, publishing books and papers long before I got into this field. And Malcolm Kendrick, Michelle DeLauer, and frankly, I hate to start mentioning names because there's so many people, and I'll leave people out. And so many people, in fact, if you go back decades, George Mann battled to get people, and he was a professor, and battled to get people to understand the real cause of heart disease. John Yudkin emphasized it's high blood sugar that's contributing to heart disease, and he published papers in the 1960s on this. I have benefited from not only the people I've worked with, which include cardiologists, other MDs and researchers. So yeah, I'm not alone. I have been able to integrate what I've learned from these other scientists, and I appreciate your input as well.
Sure. Well, thank you. Is there a different approach to somebody with FH who is homozygous versus heterozygous?
So homozygous FH is extremely rare. It's just emphasized, it may very well be 1 in a million people. And these are people who do die young. It's very rare for someone to be homozygous FH and survive longer than 15 years. And when I've given a talk, I've had physicians, I've talked to cardiologists, and they say, and their arteries are just filled with cholesterol, and they've got extremely high cholesterol, it could be 600. But I did find one paper published about 50 years ago that actually measured fibrinogen in people with homozygous FH. And it's about the highest level of fibrinogen that I've ever seen. So again, the LDL in these people may be leading us astray. And so it's essential, first, when we talk about homozygous FH, which means you get it from both parents, that we need to look at other measures and not just blame the cholesterol. Now, heterozygous FH, meaning you get it, this anomalous gene from just one parent, these are the people who live long, healthy lives, despite having high LDL. And it is the subset of these people who appear to have, or one of the genetic anomalies, I have it in one of my papers. So it's prothrombin is a clotting factor. And there are different genes for prothrombin. People with FH as well as non-FH, this is just found in all people. There is a form of prothrombin that increases clotting, increases the tendency to spontaneously produce clots. There's a nice paper on FH in which you have two groups, one diagnosed with heart disease, one without heart disease. And the crucial difference is this genetic anomaly of prothrombin. The people with FH that had the heart disease had this very same genetic anomaly you find in the general population. So we have published now 3 papers on FH, emphasizing that we have been led astray by focusing on high LDL. First, what we need to do is look at their clotting factors. And if someone has FH, or frankly anyone with extremely high clotting factors, start with fibrinogen. And there are others, factor VIII is another one. You should get a blood test and look at your clotting factors. That's one thing. The other thing I want to emphasize is clotting factors don't spontaneously ignite. They are there to protect us in case we bleed. What triggers the clots without a wound is hypertension and blood sugar and stress. And so that activates these clotting factors. So the thing for people to realize is it's good to know your clotting factors, and it's easy to get with a blood test. It's even more important to realize you want to keep them calm. Okay? You don't want angry clotting factors. You don't want angry platelets. You keep your platelets happy and calm by keeping your blood sugar low, by controlling your stress, by exercising. It's kind of interesting, by the way. Exercise actually activates our blood clotting. And it's a bit like the predator that's chasing down the prey. That's exercise. But then once the exercise is over, we have a system called fibrinolysis to break down those clots. So we have this balance, which actually is covered nicely in Malcolm's book, between prothrombin, in which you're activating clots, and then fibrinolysis, in which you now break down those clots. Well, if either one is off, well, then you're more likely to have clots. You have more strokes, you have more heart attacks. So this is what I'm emphasizing. The people who study FH are focusing on LDL too often. We don't have enough information on clotting. So if you had a patient with FH, LDL could be 250, 300. What I would suggest to the patient, first of all, is it's so important. First, obviously you don't smoke, but it's even more important for the FH person. Get the blood test and find out their clotting factors. Keep the blood sugar low, keep exercising, and keep those platelets from getting angry. Okay? And then, in a sense, the clotting factors themselves are not as important as the context in which the clotting factors exist.
So we have taken your advice, and we do check clotting factors in patients
Right.
that have a pattern of FH. And so one thing I wanted to ask before we shift away from FH is it's my understanding that patients come in and they say, I have FH. And I said, well, were you genetically tested? No. Well, they have a pattern suggestive of FH. And you really, having a pattern of a high total cholesterol or LDL cholesterol and low HDL can be suggestive, but you really need to do the testing and do the genetic testing to see if you have a receptor defect, a genetic defect. And this is really opposed to, we see these lean mass hyper responders, to mention the term from Dave Feldman, and they have high LDL cholesterol, but their triglyceride to HDL ratios are beautiful, and all their other inflammatory markers are good. So, they're just lean mass hyper responders. They're not FH.
Right. I would suggest there's no real benefit to doing genetic testing.
Right.
It truly, one thing that's happened is because pharma dominates so much of the way that physicians think and the guidelines are developed, that if we can increase, this approach from pharma, increase the percentage of people that are diagnosed as having FH, then automatically they're put on a statin. I mean, it's considered unethical not to treat someone with a statin if they're officially have FH. And I would say that's completely, first of all, in the absence of any clinical study that has ever shown a benefit of statins compared to placebo. It's been considered unethical for 60 years to have a placebo group for people who have FH. So we don't really know if statins will have any benefit for people. And what's, I think, unfortunate, we've actually written a bit about this, they're now doing blood tests and genetic tests on children and getting them on statins as adolescents. And I think that's very unfortunate. So my point is, whether FH or not, genetically FH or simply high cholesterol, if you focus on the clotting factors, then FH becomes moot because the cholesterol doesn't matter.
Your points are well taken, David. And so getting back to the paper, I think the last aspect is whether to statinate or not, or, to medicate. And, you said it today, you said it several times in the paper, full transparency, that we just don't know. So, I think your paper suggests, although, I have to say the title is provocative, and perhaps it's misinterpreted, but, you're suggesting that anyone on a low carb diet that has a favorable atherogenic profile should not be on a statin. And, diving into the paper, just looking at the evidence to make that statement, you mentioned the post hoc 4S study and Prosper. And, there's some problems with post hoc. I'm not a researcher. I don't analyze the data like you do. And then I think Prosper was a small study. And it was just, in that data, it showed that the patients that had an LDL pattern that was perhaps favorable didn't benefit when they were given a statin. And it's just a suggestion. It's not really kind of a hard finding.
Well, let me elaborate. So the 4S study was one of the first studies ever on a statin, and it had the largest effect pretty much of any study, and it's been criticized. The 4S study was secondary prevention. It was basically designed, implemented, and there's an absurdity in there that people like to make fun of, that Merck analyzed the data. Okay, it was not done by an academic. The data were analyzed by a Merck employee. Okay, so that's an obvious problem with the original study, which showed about a 5% benefit in mortality with simvastatin treatment. Okay, but let's set that aside. Christy Ballantyne is the first author on the reanalysis, and I don't think he fully appreciated what he showed in his reanalysis, which was published about 8 years later. And this is so important. This is actually why I don't say that statins don't have a benefit. And it may very well be it's because the people who are most unhealthy will benefit from a statin. Yes, I've said it. Benefit from a statin. So let's look at what the reanalysis showed us. I think it's so important. What kind of people, speaking about their metabolism, will have high triglycerides and low HDL? These typically are people who are overweight, they have metabolic syndrome, they have high blood sugar. These are people who are unhealthy and also will have more small dense LDL. The benefit of statins for those people was huge. It was the biggest benefit I have ever seen. The difference between placebo and treated group was 15%. And that's absolute risk. That's not relative risk. It was about, you're looking at it like 35 to 20%, something like that. Is that, am I got my numbers right?
Yeah, and is this the,
yeah, okay, this is figure,
I put the paper up, David.
This is so important. Let's look at figure 3.
It's on the screen.
Okay, the placebo on the atherogenic lipid triad, which I would actually say someone corrected me, and I think it's probably better to call that the pattern A from Ron Krause's work. And pattern A means high triglycerides, low HDL, which is the atherogenic kind of triad. And so let's look at the rate of events for people that got the placebo, which is like 35% of them had some coronary event. And those given simvastatin, 19% of them had an event. So you're looking at a 16% real reduction in rates, which is the largest ever recorded in a statin study. To give statin its due. Now let's look at the people, and all these people have high LDL. That's a given. They start with high LDL and they end up with the same LDL levels. So LDL is sort of canceled out of the equation. Now let's look at the people who have low triglycerides and high HDL, which is the kind of lipid profile you would see for someone on low carb diet. And first thing is look at the placebo. So the placebo people now have a much lower rate of events. They're having events at about 19, 20% of them. So it's dramatically lower than the placebo group that was unwell. And these people given the statin show no statistically significant difference in rate. Like it's a couple percent, but it's not significantly different, meaning there's no benefit of the statin. This is such an important study in hindsight because it's telling us that statins are doing something other than lowering LDL because there's a dramatic effect here. And that's why in our paper on the right side, we're saying it has no relation to LDL, but there is something that statins are doing for the unhealthy person, essentially that doesn't want to go on low carb and improve their lipids. And this I attribute to strong anticoagulant effects and anti-inflammatory effects, which contribute then to heart disease. And that's why I think that's an important study. And frankly, the first author is a strong statin advocate. And I actually look at this, what he's saying, what that group is saying is that if you are well, if you are healthy, if you're low carb, he didn't know he was saying that, but that's what he's saying. If you lower your triglycerides and raise your HDL through a change in lifestyle and diet, then this study says there's no reason to expect a benefit from a statin.
That's a great explanation, David. And I would tell you that this really mirrors what I do in clinical practice. And so if I have patients that are compliant with diet, in particular in primary prevention, I don't think there's a role for statins. But in secondary prevention, for patients that are compliant, we really do have to look at what's going on, and we have the discussion, and we want to give the best advice to our patients. We want to give them every tool they have to prevent them from having an event or dying from all causes. And so
understand that 4S was secondary prevention. So if you go back to that figure, the people who now have the good triglycerides, low triglycerides, high HDL, this is secondary prevention. There was no benefit of the statin.
Yeah. So
now,
jumping ahead. Yeah, I realize that the 4S study here is secondary prevention, and so that's what I was kind of heading towards, is that what do you do with these patients? And so if they continue to be really compliant with diet and lifestyle, doing everything they can. So I say, look, here's the data, here's what we know, here's what we don't know. Statins are still not a panacea in secondary prevention, but we have the discussion, and it's their choice. And then certainly if we have patients unfortunately we have patients that have a hard time complying, well,
right.
We throw medication at them. We're great at doing that, but we would prefer to address lifestyle and diet.
And I would be a little cynical about it. And I do say to people, listen, if you don't want to change your diet and lifestyle, well, then there's actually evidence that statins will give you a benefit. But if you bring up that page again, what has been clearly understated, that's on that same page, if we look to the right of that figure, one thing that I have seen basically from the people who are emphasizing the importance of statins is that essentially they're saying side effects are all in your head. These are very safe drugs, and you have really no basis for being concerned about the adverse effects. Well, if you look at that paragraph right where that hand is right here, we didn't do a full review of the entire literature, but we've got about 40 publications describing serious adverse events that occur with statin use. And I'll go down to the bottom. The cognitive deficits are very real, despite the fact that this has been minimized. And there is one incredibly important study that has been entirely ignored, published a decade ago, in which you have people spontaneously coming to their doctor being diagnosed with dementia. These are 75-year-old men and women, all diagnosed with dementia, all of them on a statin. And as an experiment, they took them all off the statin. And now a month or two later, and they've all got now higher cholesterol, so they've stopped their statin. They're given a cognitive test. And as a group, the dementia has disappeared. Their cognition has improved dramatically. And the critical test, now they're all put back on the statin, and the dementia now reappears. So we have an incredibly high percentage of our elderly population on statins. And so now the question we really need to ask is, what percentage of those people now, in which we have an epidemic of Alzheimer's disease, what percentage of those people on the statins are actually having it caused by the drug instead of it being organic Alzheimer's? And to emphasize this again, I published a paper with a group here at USF, and this was about 10 years ago, in which we looked at FDA adverse events. And we compared cognitive adverse events with other adverse events, and for each of the different statins. And what we published is that the statins that are able to gain access to the brain, so the brain has a certain protection called the blood-brain barrier. Not all drugs can get into the brain. Not all statins can get into the brain. The brain produces its own cholesterol. It's got the metabolism, the machinery to make its own, it's protected from the body. It makes its own cholesterol. So the drugs that can get into the brain are the ones in which you find cognitive deficits. So Lipitor goes right through the blood-brain barrier and can stop the brain from making cholesterol. And if the brain can't make cholesterol, it interferes with neurogenesis, the ability to make new brain cells, synaptogenesis. It interferes with the ability of the brain to make memories. And so this is where I emphasize to people, and this study, by the way, is not even mentioned by the American Heart Association in its review of statin adverse effects. So we really need to think seriously about how statins are not benign at worst. That, in fact, when you put your patient on a statin, there can potentially be very real adverse effects and questionable benefits for someone that wants to change your diet and lifestyle.
So to that note, I would say that we're very good at deprescribing medication under the right context. So
Great.
Thanks for sharing us.
Including insulin, I assume.
Yes, absolutely, Dave.
Yeah.
Yeah, so thanks for going through the paper. We're going to hear more about it at the conference. And so just to finish up, what do you enjoy about going to these events in person?
Oh, well, first, it's amazing the feeling you get at these meetings in which you see it's not just about science. You're seeing people improving their health. They want to learn how to improve their health. I'm learning from other scientists and clinicians because there is really so much to learn, not only about the cholesterol and the pharmaceuticals, but also about food. I'm learning every day about how food affects our mental and physical health. So I love coming to these meetings and just having this sense of camaraderie first, and seeing people learning how they can take control of their health. I mean, there's just this tremendous sense of it's proactive. It is learning aside from the conventional dogma, which is really very much drug-centered, to see how you change your diet and lifestyle in a way that's beneficial. And you know, there's no personal philosophy. It's not like people are saying you need to become a vegetarian or you need to follow this kind of diet. It's really all about, it's learning new information that ultimately improves your health. So I love being at these meetings.
Well, great, David. So how can the audience find out more about the LDL skeptic?
Well, you know, I don't know if you saw it today. I'm pretty much on Twitter almost every day. Sometimes battling with doctors, often getting support. Today, I put out a YouTube from a doctor who uses low carb diet to help his patients with diabetes so they don't have to have limbs amputated. So yeah, my Twitter username is LDL Skeptic. I put information out that when I learn about people who are conducting research, I share with my group. I'm almost up to 30,000 followers, which to me is just extraordinary. I feel frankly humbled and honored to be able to do this kind of research and share with people. So yeah, I wholeheartedly hope that people will see this paper bring it to their doctors. I think this is the kind of information through Twitter that people will get access to my paper as well as from the low carb meeting. Share that paper with your doctor, and hopefully the doctor will read it and think about it. There has been backlash. There are cardiologists who refuse to read my papers, and I think it's a shame. And I've battled with them on Twitter. But I'm looking for the people who are the most open-minded, physicians like you and patients. So I don't do Facebook much, but I really use Twitter far more to share what I've learned.
Well, if you haven't followed David on Twitter, I would suggest you do so. He always puts out fascinating information. Again, that's LDL Skeptic. And David, again, we're looking forward to having you return to low carb for another presentation.
Wonderful. Thanks again, Jeff, for inviting me.
Oh, my pleasure. And for our audience, if you want more information about our conference, please visit lowcarbconferences.com. And until next time.